de contar com a participação do professor Augusto Enrique Caballero-Robles, que aceitou de uma forma muito gentil esse convite, e é uma grande honra para nós ter a sua presença aqui, né? O professor é bastante conhecido de todos nós, através de cursos da Harvard, através de apresentações em congressos, e ele é um profissional endocrinologista, investigador clínico e educador, né? Ele está envolvido em múltiplas atividades em áreas de cuidado do paciente, educação, pesquisa clínica e educação profissional, que ele tem se dedicado de uma maneira muito especial e também com uma atenção especial para a comunidade latino-hispânica, prevenção do diabetes, da obesidade e a interação entre diabetes e doença cardiovascular. Ele foi co-investigador de inúmeros programas muito importantes na área de diabetes, como o National Diabetes Prevention Program, o Look Ahead Program e Diabetes Education Study, todos eles, né, sobre o comando do National Institute of Health. E o professor Caballero, ele recebeu inúmeras premiações locais, regionais, internacionais, e, recentemente, no Congresso Americano de Diabetes, que ocorreu em junho, ele recebeu mais uma premiação como Outstanding Education Award. E a sua apresentação nesse congresso, ele vai também fazer uma participação aqui conosco. Professor Caballero, muito obrigado por ter aceito o nosso convite. É uma grande honra e um grande prazer contar com a sua presença aqui entre nós. Obrigada.
Muito obrigado, bom dia. É um prazer estar com todos vocês aqui. Mas eu falo portunhol, é melhor trocar para inglês. But it's really a pleasure to be with all of you here this morning. It's early here in Boston. It's 6 a.m. So I had to wake up a little earlier than usual, but it's really wonderful to be here with all of you. And I hope that you like this presentation, which is basically what I presented at the American Diabetes Association meeting in San Diego in June of this year. As you heard, as part of the recognition for this award in education, which has been really a focus of my career over the years. And what I would like to do is to share some thoughts with you about diabetes management and some of the challenges that we have, but also some ideas perhaps about how to improve the care that we provide to patients with diabetes. I have no conflicts of interest with anything that I will present today. So these are the different topics that I will review with you in terms of the background about where we are in diabetes, but also, as you can see in the title of my presentation, is about listening to multiple voices. And what that means is that we need to recognize the needs from everybody that is involved in diabetes care, of course, our patients, but also what's happening to us as healthcare providers, the healthcare system, many other players, and then I will make some closing remarks. So briefly to start, I will say that diabetes, of course, has been a major problem over the years, not only in the United States, but in many areas around the world, including Brazil, for sure. And despite the great advances in diabetes care, most people with diabetes are not achieving the basic treatment targets. For example, as you can see here, 26% of patients with diabetes in the United States achieve the basic treatment targets that are good A1C control, blood pressure control, non-HDL cholesterol control, and non-smoking. So only 1 in 4. And that is actually not very good. It means that all the great technology and all the great scientific information that we have in the field of diabetes, we understand better than ever before the pathophysiology of diabetes and the complications and all the different problems that are happening. But yet the impact that we're having in patients is not that great. We are helping, of course, a lot of patients, but we're not helping the vast majority of individuals with diabetes. And the other big piece, which I am sure applies to Brazil as well, is the fact that we are spending too much money in diabetes care. And as you can see here is a study that we did with the Medicare population in the United States, which is covered by the government. And we found that 70% of all the money in diabetes care is spent in only 15% of the patients with diabetes. Now, these are most likely the patients with diabetes and chronic complications. And many of them belong to racial ethnic minorities. Here in the United States, we have a big challenge with the African American, the Black population, also with the Latino population, which has been the focus of my career for many years, including people from Brazil that live here in the United States. And also the fact that we are really not using the money to treat diabetes. We're using the money to treat the complications of diabetes. That's not a very good use of the money in healthcare, to pay for the complications of a disease. We need to do things much earlier, prevent diabetes, treat diabetes properly early on to prevent the complications of the disease. In the US right now, $1 out of $4 in healthcare in general are spent in diabetes and its complications. So it's really a very expensive condition, and we're not doing very well from that perspective as well. And as you can see here, also in the world, we're spending a lot of money in diabetes. This is global data. And so $966 billion per year, which is a huge investment in diabetes care. Now, of course, this is different in different countries around the world. There are countries you can see there called high-income countries where there's so much money that is spent, and some in which very little money is spent, low-income countries, because, you know, there are so many other challenges, not a lot of investment in the disease. And it's difficult to really get to a specific point that we could say it's the ideal amount that is spent. But the reality is, as you can see on the left, there's been a 316% increase over 15 years in diabetes care. But the impact, as I said before, is not really great. So I think we need to think that the way we're spending the money in healthcare and in diabetes care is probably not the ideal way. So I call this presentation listening to multiple voices. So the first thing to recognize is what the difference is between hearing and listening, which is obviously more a grammatic and semantic issue. But so hearing is the process, function, or power of perceived sound, specifically the special sense by which noises and tones are received as stimuli, whereas listening, on the other hand, means to pay attention to sound, to hear something with thoughtful attention and to give consideration. So we may hear a lot of different things, but we're not actively listening. Listening is really paying attention. So I am sure that if, for example, I ask all of you to raise your hand if anyone in your family, whether it's your spouse or your children or anyone, has said to you, "You are not listening to me." And I think that that is very common. We may think that we are listening, but we're not actually paying too much attention. And the reason why I say this, which sounds like very silly and very basic, but is the fact that we don't actually pay too much attention to the needs of everybody that is involved in diabetes care. And I think we need to do a better care in that way. So let's start with the patients, who are, of course, the center, should be the center of our attention. And let me introduce you to three different cases. that I am sure will resonate with you in terms of the people that you may actually see somehow in your practice. So they all are Latina, Hispanic women. Here is the example. All of them are 58 years old with type 2 diabetes for 10 years. They're overweight or have obesity. They have hypertension, dyslipidemia, and history of coronary artery disease. And you can see there their blood pressure is 150/94, A1C 8.9%, LDL 102, and they all struggle to improve their lifestyle. And they have been taking medications for diabetes care for a long time to manage all these conditions. So does that sound familiar? Very typical case of someone with type 2 diabetes. But their living conditions are very different. This is Mrs. A, who lives here in Boston. She works full-time as an accountant. She is divorced and has one son. She's fully bilingual and bicultural. She's under constant stress due to work and being a single mother. She has full health insurance, eats out frequently, and has no time to exercise, often forgets to take her medications, and she's frustrated by trying to improve her diabetes targets without success. So she has, of course, her own challenges. But here's Mrs. B. She lives in Lynn, Massachusetts. That's another area here in the state of Massachusetts, which is really not in a big city. It's really far away from the main city. She's a housewife. She's separated with 3 children and 2 grandchildren. She doesn't speak English well, which here in the United States, that's a big challenge because then access to healthcare and the benefits of interacting with people is actually much more limited. She has a low health literacy, low education level, and often requires assistance to follow her treatment recommendations. Her health coverage is limited. She has food insecurity, which means that she has really not enough money to really buy proper foods and healthy foods as recommended by her treatment plan and team. And she lives in a neighborhood that is not very safe. And then we have here Mrs. C, who is a person who lives in a very rural area in Chiapas in Mexico. She's married with 4 children and 8 grandchildren. Her husband works in the field. She takes care of their grandchildren. She has access to a small clinic, and the closest hospital is 4 hours away by bus, and can only afford to eat rice, beans, corn, and tortillas and chicken on some special days. And her access to medications is obviously very, very difficult. So if I had shown you only the first slide with the general information, you would think that they are probably very typical, identical patients, but there are very, very different voices that we need to hear from. So their needs are very different. All of them need, of course, support in how to overcome the challenges that they have, but the strategies that we have to implement should be really very different across the board when we do this. And the reality is that we don't usually have the time or sometimes the resources or the structure to help patients when they have all these different needs. Now, a few years ago, I decided to create this list. Some of you may have seen that before. I call it the A to Z list for the management of diabetes. And to be very honest, that came from the frustration that I had of not having a good impact on my patients. And I created this list that reflects all the factors that have been described in the literature that have been connected with diabetes outcomes. So one way or another, every single one of them is important in diabetes care. They are organized in alphabetical order. There's no order of importance, but if you go through the list, you will identify that there are things that you routinely talk to your patients about, but many others that probably you don't really pay too much attention. And I think it's important to recognize that all of these factors are important. I'll be happy to take any questions as we go along a little bit later, but this is my working list that I have with me. Obviously, I don't assess all of them in one single visit, but I probably pick 1 or 2 to discuss with my patients in terms of how this may be affecting their diabetes management and care. Language in the United States is actually a major issue, and not really sure whether that would be applicable to the populations that you see, but obviously here is really very important. And I have this really story, real story that happened a few years ago here in Boston, where a patient received the prescription that you see there on the screen that was called or was written for lisinopril 10 milligrams, and it was signed as take once /D. Now, the patient didn't speak any English, and then the patient was actually rushed to the hospital. And you know what happened? I'm sure that you identify what happened. So she didn't speak any English, and she read once, which for her was once, which is 11, once in Spanish. And of course, you know, she followed the instructions. This is a real story. She took 11 tablets of the medication, and she could have, of course, died from this, but fortunately, she didn't. But this is a huge mistake. And obviously, I always say this because that happened in a community health center here in Boston many years ago. And now, of course, we need to be sure, this is what I have learned, is to really be sure that people understand what we are telling them to do. I don't let any patient leave the office unless he or she truly tells me in their own words what we have agreed and how they're going to do things. It takes time, but this teach back moment is absolutely important with all our patients. So communication is crucial. I think it's important that we need to recognize that things may not be really happening exactly in the same way with all patients. And you know, I share this piece here because in English there's also confusion about some of the words. For example, when you clean some furniture, in English you say that you're dusting the furniture, which in my mind doesn't make too much sense. Probably should be de-dusting, not dusting the furniture. You want to get rid of the dust, not putting more dust. But you know, that's just the English word and how it is used. But there may be some things that may be actually a little bit difficult for people that don't speak that particular language. But the other big piece is about food insecurity and access to food here in the United States, which is a big problem. You may not believe that that's actually true, but it is actually true that there are people who don't have access to good and healthy foods here in the US. And you can see here on the right a map of the areas that have high food insecurity conditions, or what we call food deserts. These are areas where even if people want to have access to healthy foods, they just don't exist there. It's only more the pre-packed foods, the processed foods, the food with high glucose, carbohydrates, and saturated fats that are available only, and very limited access to healthy foods. Now look at the map here on the left, and these are the areas with the highest concentration of diabetes. And you can see that they are very, very similar. So it's not a coincidence that those areas that have the most significant challenges to access healthy foods are the ones with the highest prevalence of diabetes. And these are the areas, by the way, where many of our patients, our people from the Latino community, from the Black community live. And so it's not surprising to see that the risk for diabetes is much higher in these communities. Now, I also want to share with you that I have over the years tried to look for some potential opportunities to really bring people together in our culture and trying to see how we can do things better with patients. And I don't know if you are familiar with this model, but I like it very much. It's called group medical visits. It's not an education class. It's not that you just get together a group of patients and teach them something. That's very common, and that should be done. But this is actually a medical visit. So instead of seeing patients one after the other, one by one, I sometimes get them all together, as you can see there in the screen. And then in that group setting, I go one by one addressing their medical needs, but everybody else is listening to what's happening to another patient. It's really a very interesting model. You need to know how to handle and time and how to allow people to participate and at the same time cover their needs and listening, to their needs. But it's a model that could be very effective in the sense that people are learning from each other and they spend more time with me. In an individual visit, they would be with me probably for 15 minutes, 20 minutes. In a group visit, they're there for 90 minutes. So they're learning a lot about what's happening in diabetes, and they kind of have answers to their questions more effectively. There's usually an educator with me as well. So whether that's a dietitian or a nurse, and I obviously take that as an opportunity for education, and then we discuss many of the things that are happening to the patient. So that's another interesting model. Obviously, we always address confidentiality, so people need to know that they don't have to, of course, talk about everything. We could actually meet individually later the same day or in another visit. So it's something to just keep in mind about different strategies to provide care to more patients in an effective way. But education obviously is important, in the food area. I actually created a salsa dancing program some years ago for my patients because, of course, as a Latino person, and I'm sure that I'm talking here to the people that dance the best in the world, the people from Brazil. So, of course, finding ways to engage the community in something that is really very attractive and important, I think is a good thing to consider to provide education to our patients. Now, in the food arena, I think we are struggling always to guide patients properly because we always tell them, what to eat, and we give them a list of things, but nothing really happens when they go home. A few years ago, we did a study in which we actually decided to go to the supermarket with the families to teach them how to bring better foods home because people don't know how to do that. So the educators in my team went with the families to the supermarket, and they were able to learn, the patients were able to learn how to better buy the foods that they would bring home. And we had a good impact, and they spend not more money, because that was the promise in the study, not to spend more money, but with the same amount of money, be able to bring better quality of foods home. And that's something that was really great. Now, I am not saying that you need to go to the supermarket with your patients and families, because that would be impossible. But how about maybe using technology now? One of the things that we're doing is communicating with our patients via videos when they are at home, and they can show us what they are eating or what they have in their refrigerator, so that we have a better idea of what they have at home, because that's what they're going to eat. And also cooking demonstrations and many other things that can be done virtually is something that we have not really made part of the healthcare system, but I think that's important. So the old traditional way of just telling patients what to eat and just giving them a list may not be enough for the vast majority of patients. So think about something that could be really different. Now, this is a picture. I'm here in the center when I graduated from medical school in Mexico. That was a few years ago. And when I finished, I thought that I was ready to solve all the problems. And I know that in the audience, there may be many young people who are either finishing medical school or doing their residency or their fellowship, their training. And I am sure that everybody's excited about medicine and solving all the problems in the world. And I thought that I was ready at that time to solve all the problems in the world. But then as part of my training, I spent 1 year in a very poor community, a rural community in Mexico. It's called here Ciudad Nezahualcóyotl in the Estado de Mexico in the country. And I was so sad and frustrated because everything that I learned in school about the pathophysiology of the disease, about treatments and technology, is something that did not make any sense here. There was nothing that I could do. People were struggling in finding ways to survive and eat, and they didn't have a stable home, and they didn't have the basic needs. it was a very important experience in my career because I realized that one thing is to learn about science and another very different thing is to actually implement all these things in the real world when there are so many challenges. So I decided and promised myself to think about that as I went along in my career. And later on, I had the opportunity to come to Boston, initially to the Joslin Diabetes Center that probably you have heard, which is a great center only dedicated to diabetes here, affiliated with Harvard in Boston. And that's a picture from when I joined some years ago in the research center. This is Dr. Horton, who was kind enough to offer me a position later on to join the staff. And then I decided to stay here in the United States, but I always had in my mind the idea of trying to find solutions for all those people that have really struggled with all these conditions. And life gave me the opportunity actually through the years to do some of this work. So eventually, for example, I was able to do some work in Mexico, where I am from originally. And there's this state called Chiapas, which is in the south of the country, and it's the poorest state in the country. And there is a group that is working with different people here in all these areas. These are small clinics that provide care to the poorest people that live here with very, very difficult conditions. And this is a very small clinic center, basically for people to go and get some care, which of course with very precarious, very difficult conditions. And I've been working with this team for many years. I live in Boston, but I really have tried to work with them closely. And, you know, these are some of the activities that are implemented there in terms of education. Education can be done at all levels. I think that it doesn't matter where you want to do it. If you do it correctly, I think that there could be an impact with patients in the conditions that you may have. And this is the team that works there. And I call them the superheroes because they are outstanding. They really don't have a lot of support and resources, but they do miracles with patients in all the limited conditions that they have. And we have a diabetes program there, and there are people with diabetes in this population. And it's been really very nice to see how we have been able to help them, although we sometimes have no medications, no insulin, no testing. Only 10% of the patients have had an A1C that has been measured. So it's very difficult to do things, but I think it's very important to try to help those that are really with the highest needs. And it's really rewarding to really work with these different communities. Now, I would say and summarize here that for patients, we have to listen to their voices. Everybody's different. Everybody has challenges. And I think it's important to become familiar with some of the options and some of the resources that could be offered to patients in our communities. Now, let's briefly talk about us, the healthcare providers. And I'm sure that you agree that, of course, we have a lot of challenges in providing care to our patients. We don't have the teams, we don't have the time, we don't have the resources. And truly, we're very tired at the end of the day because we work a lot. The impact that we have may not be great. We're not well compensated. We have no resources. So it's really a very challenging situation. So I think that we also need to think about this. And perhaps some people that are in charge of the hospital are listening to me right now, because I think that I appreciate the fact that people need to find ways to provide good care and stable finances in hospitals. But I think it's important to think as to whether we are really investing the money wisely in our healthcare systems to also provide support to healthcare professionals. And not only do we have challenging conditions to work in, but we have to learn a lot all the time. To be in education is not simple, so we have to be updated. So I did this search recently, and if you look at diabetes-related information that has been published, so it comes out to you having to read about 73 articles every day, just in diabetes, if you want to be updated based on the number of publications. So that's obviously impossible. So, you have your own education activities like this one, in which you have some sessions, some seminars, some conferences. You may attend different congresses in your country or abroad. And, there's a lot of information out there in the media, and LinkedIn and Twitter and many other places. So it's hard to dedicate time to really provide ourselves with the level of education that we need, but it's really very important. And that's been another fascinating area in my career, for sure. I've been really privileged to direct many Harvard education programs across the world. These are some pictures from different areas in the Middle East, in Asia, in Latin America, that we've been able to implement a lot of different programs to help healthcare professionals not just learn the latest scientific information in diabetes, which, as I said, is fantastic, but it's also about how to implement things in real clinical practice. That's the challenge that we have. And, this is a question that I always ask, and I would ask you to answer this question for me. But if I ask you, what is the most important barrier preventing your patients from achieving treatment targets? Is it that you don't have time with patients? Is it that you don't have education programs? Is it that you don't have a team? Is it that people don't follow the recommendations? Is it the reimbursement, the financial piece in the hospitals? Is it that you don't have access to medications and devices? Or is it that you don't have sometimes all the knowledge to really solve the patient's problems? Everywhere around the world, everywhere I go, people usually say, oh, it's the patients that don't follow the recommendations. That's the problem. And I would say, really? Is that the main problem in the field? I don't think so. I don't think that patients necessarily don't do things in order to hurt themselves. I think that sometimes it's just that they don't have the ability to do that for lots of different reasons. And I know patients are not perfect, and many patients don't follow recommendations, but I don't think that we need to blame them to say that that's the reason why we're failing in diabetes care. I would like at some point to hear people saying, well, honestly, it's because I don't know how to help my patients. That would be the most mature answer from my perspective, because we need to learn more, not only about science, but how to help our patients. And if we reflect on that, I think that we would be better off in doing that. And I've been working with also medical students and very young people for years. These are the students at Harvard Medical School that are the future doctors. And we're trying to really help them think differently about how to tackle all these problems. Science is fantastic. I love it. And I would be happy maybe in another time to talk about that part in diabetes care. But I'm very passionate also about how to implement all these strategies in real world. And we have different programs here. For example, we have a program in which people can come here to Harvard and they spend some time with us learning about diabetes and other areas. And we've been able to actually guide them in implementing different programs when they come back to their country. And that's been really a fascinating area of work as well. As I said, I've been very privileged to really work in the field of professional education as well for years. Now, during the pandemic, everything became more difficult, of course, because then traveling to all the different places was not possible. So as many of you, I was able to also appreciate and now give lectures, not fully dressed, but only from properly dressed from the waist up, probably the way I am right now. But I think it's been just a way to transition during this pandemic in doing things differently. And I don't know what's going to happen later on. I think that now we all appreciate all these virtual presentations. I still love to have that direct interaction with people. And I think that's something that we need to consider as well. But I think that the field of education has really expanded and evolved, and it's really very important to embrace it properly. Now, I want to leave a few minutes for your questions, but let me just briefly touch on the healthcare system, because this is really very important. So we all work in a healthcare system. We interact with our patients, and we're trying to really provide them with the information to improve their self-care behaviors. But as I said, we're not helping most patients with diabetes. We have what I would call a reactive model of care. What does that mean? People come to us when they are sick, when they're not feeling well, and we try to fix the problem and send them home, and we don't see them again. And who knows when they're going to appear in the system, maybe in the hospital when they have a complication. We don't know that. That's not a good model of care. We are not really paying attention to many other things, and we're concentrating only on the biomedical piece and not the psychological, cultural, and socioeconomic factors that affect people. And so we also need to, again, think about how we can get better in doing all these different activities with our patients. But the model, the system that we have is very limited. We have a limited time with patients. We don't have sometimes the resources and the support to do this. So we need a team. And these are all the people that I think need to be part of a multidisciplinary team for diabetes care. Everyone here in this slide is important. It's not just the doctors, it's the educators and the dietitians and people in behavioral health and case managers and social workers and nurses and interpreters, patients navigators. I believe that actually people from the same community can help other patients effectively. So we actually need a lot of different people. And maybe you don't have everyone in a diabetes care team in your hospital or in your clinic, but everybody is really important. And I have also worked over the years in trying to educate patients to help other patients. This is the peer support concept in diabetes care, and that has been well demonstrated over the years. And here, for example, you see a picture in another program that we have in a rural area in Mexico as well. These are people from the Mayan community. They don't even speak Spanish. They speak their own language, Mayan, and we trained them in order to help other patients in the community, and they were able to improve a lot of their diabetes care behaviors. So there's a lot of emphasis now on what we call the social determinants of health, and these are the 5 domains that have been recommended according to a recent consensus from the American Diabetes Association of things that we need to pay attention to in all our patients. Obviously, their socioeconomic status, where they live and how they live, the access or the lack thereof of food in their day-to-day activities. How are they accessing the system, and also their social context? We as doctors, honestly, don't pay too much attention to this because we have so much to discuss with patients about their blood pressure, their A1C, their weight, their cholesterol. That takes most of the time, and we prescribe medications, and that's the end of the story. And we don't have neither the time nor the ability or the knowledge on how to address these things. But I think this is extremely important when we're treating patients, not only with diabetes, but with any medical condition nowadays, because we know that that's actually even more important than anything else that we are going to be discussing in terms of the pathophysiology or pharmacological treatment of the disease. So here's a picture of the beautiful Brigham and Women's Hospital. This is where I work now. I said that I worked at the Joslin Diabetes Center for many years, and then I transferred a few years ago to the Brigham and Women's Hospital, which is a much bigger hospital. All of them are Harvard affiliated. And this is a beautiful building there where I could see my patients, but I decided at this point in my career not to do that. I don't want to be in this very fancy, luxurious place. I want to be closer to the patients that I want to help. So I see patients in this very small center called Southern Jamaica Plain Health Center. It's here in Boston, but it is embedded in a community that is primarily from the Latino, Hispanic group and the Black community. And I feel much closer to my patients because I know where they live, I know where they go, where they eat, where they shop, where they can exercise, and all these different things that I decided to do in order to really better understand and better listen to their needs. And it's something that has been really rewarding. And this is the team that works with me. Obviously, this was taken in the middle of the pandemic with all the masks, but I have the privilege of having people that work in that are social workers, navigators, and patients that are really very close to patients. And we have a fantastic team. And we're doing different programs. And one of them is called the DICHA program, in which we're trying to really help patients, not just from the scientific perspective, but also by going to the communities and working very closely with them in order to improve their self-care behaviors and really having a better impact in what they are doing. Now, let me just finish with a few other things here. One of the things that we all need to recognize is that the pandemic obviously was terrible, but it was also a teaching opportunity. I was privileged to lead this international consensus in which, in the middle of the pandemic, we got together people from different countries around the world to discuss what was happening in diabetes. And here's what I would say the main teaching point here. And this is what we were doing before, what this reactive model that I was talking about, that I call the previous diabetes care, waiting for patients to see us, providing them with some general information and sending them home, not addressing the social issues. And then during the pandemic, they couldn't come to us. We couldn't see them in the hospital. So we had to call them at home or maybe do a video conference, etc. And now that the pandemic is slowly disappearing, it's not over yet, what are we going to do? Are we going to go back to the same thing that we were doing before that was not working? Or is it an opportunity to do things differently now and learn from that? Maybe we don't need to see patients in the clinic all the time. Maybe we can have those communications that we were having during the pandemic via phone or via, teleconferencing, and maybe work more closely in their communities and not necessarily just in the hospital or in the clinic. So I think in the future, we need to be better prepared, because people with diabetes suffered devastation from the pandemic because we were not ready for this and they were not well controlled in their disease. So I think that we need to think about this in a different way. And I'll skip this part here just quickly the other time. So let me just finish with the other voices, because we talked about the healthcare system, the healthcare provider, and the patient, but there's the government. Ultimately, this has to do with the structure of a country and policies and social structure, because access to foods and access to the healthcare system is not something that we decide. Someone else decides. And obviously that is something that hopefully people pay more attention to in order to really solve all these problems. We need the schools, the universities, to actually properly train individuals to tackle all these problems. Professional organizations, community-based organizations need to participate in this. Insurance company who pays for healthcare needs to listen to all these voices, but they have their own needs as well. So we need to listen to what they are trying to do and try to work closely together with them. Pharmaceutical companies, and there's great devices, great medications now for diabetes care, but they are very expensive for some people. I think this is not right. Everybody should have access to the best medications, regardless of their socioeconomic status. And I think this is a call for action in terms of discussing how that could be possible. So lowering the cost of the medications is one way, but also working together and trying to be sure that there's policies that governments establish in order to provide access to medications to everybody is, I think, important. And then finally, the media. I think there's so much information about diabetes out there, but not everything is accurate, not everything is good information. So really being sure that the information that is out there is relevant, I think is really important. So I would just end here by saying that we have, of course, the privilege of witnessing the great advances in diabetes care. Never before did we have as much information as we have now. But the problem is that most people with diabetes are not achieving treatment targets, and that's the reality. So we need to think differently, and hopefully I probably touched a fiber in you to start thinking probably about how to move forward in a different way. If we continue to do the same thing that we're doing now, we're not going to help most patients with diabetes. It is time to reflect on doing something different, incorporating everything that I just mentioned and listening, properly listening to everybody involved in diabetes care. And I will finish with this quote by Desmond Tutu, who is a bishop from South Africa, who has been a fighter in social justice. And he said, do your little bit of good where you are. It's those little bits of good put together that overwhelm the world. Little by little, each of us can contribute to a better world. And with that, I want to thank you for your attention, and I leave you with my professional and my personal email. And I would say, muito obrigado por darme la oportunidad de presentar esta palestra para vosotros. Obrigado.
Alô? Eric, pode parar a gravação. Obrigada. Eu vou deixar aqui.